Thank you very much for the kind introduction. His Excellency, Mr. Delcourt, Ms. Lebu, Dr. El Belushi, the Oncidium Foundation organizers, the colleague speakers, and ladies and gentlemen in the audience. It is an absolute delight and a pleasure to be here to give this keynote lecture. It brings me back to the root you heard about the need for global collaborations. And my dad, who worked for Indian government, had contributed a lot of his efforts, not only just in the upbringing and the development, but also volunteering the time. And he had already in my childhood established this concept of global giving. And it brings me back to the root, as you mentioned, His Excellency, Dubai is the hub. And what better place to have this conference than Dubai to bring up really the global need for collaborations, and also acknowledging Belgium's role in development of theranostics in 80s and 90s when there was very little infrastructure and little knowledge. And Belgium really was one of the countries that propelled the field to where it is now. So acknowledging the role of Belgium in the contribution of world of theranostics where we are today. These are my disclosures, and this is the outline. We'll talk about the fundamental concept and historic perspective, established role in prostate carcinoma and NET, landscape both local and global, and then barriers and challenges and what's next to come, which is one of the, we think that this is just the tip of the iceberg. So so much more in the pipeline that's coming through. So let's start with the fundamental concepts. There was a target that is both for imaging and therapy. This concept is not new, and many of you, it is not a surprise that this was in 1940s, but there are some in the audience who, we were discussing the fundamental concepts and not having the scientific basis. This is one of the establishment of the concept back in 1940s, where the radioiodine was used. And I am always amazed at looking at this particular slide. I was asked to give a lecture on entire presentation on the historic perspective of nuclear medicine. And one thing that caught attention was that this was MIT conference where Sol Hertz was in the audience while Carl Compton, one of the presidents of MIT, was giving a lecture. And at the end, Dr. Hertz went to him and asked, can iodine be made radioactive? And that somehow started the huge field of nuclear medicine. And this is also something to bring back us full circle, where nuclear medicine started as, in fact, therapies is the very first application, and then when morphed into diagnostic, and now we're combining all angles and bringing it into theranostics. So the concept is very simple. You have a patient who has metastatic thyroid carcinoma, locally advanced with lymph nodal involvement, and then after therapy, you're doing the scan to confirm that this is a complete treatment response. The strategy of combining the diagnostic and therapeutics was coined back in 2004 by Frank Hauser. And basically, he combined the word diagnosis and therapy and then coined the term theranostics. The concepts and the components are the considerations of a diagnostic agent to provide optimal information regarding the target expression and extent of disease, very critical step. And then the next one is considerations of therapeutic agent to provide maximal treatment while minimizing the side effects of bystander normal tissue. And the idea is very similar. You have everything in the molecule remains the same, except that one on the left, the diagnostic agent, is then replaced by the therapeutic once you have confirmed the target expression. And really what helped us in increasing the awareness amongst the general medical community as well as in the general public and regulators' eye are the role in prostate cancer and neuroendocrine tumors. So this is one of our own patients who had treatment with Lutathera or lutetium dotatate. And before and after, and you can see individual sites in the liver are demonstrating favorable treatment response. And then every time after the cycle, we are able to repeat post-therapy scans, and now we have put together the protocols for not just planar imaging to confirm the expression, but also performing SPECT-CT to get specific dosimetry calculations. And now we have started to, in fact, going into individual treatment planning for the patient. So if we find that any specific lesion is not getting sufficient dose and it's showing expression and expansion and progression of the disease, we are proactively targeting these sites to give the patient full chance of recovery rather than just showing that, oh, well, 50% of the tumor has decreased. So you can't really sit down and acknowledge your laurels just because you got some response. You need to get a full comprehensive evaluation and get the most out of treatment. And we know that it may not necessarily be just our radiopharmaceutical therapy. It will require multidisciplinary collaborations with our surgeons, with our interventional radiologists, and our targeted therapy delivery folks who can go after those outlier lesions who are not responding very well. Ultimately, the goal would be this, where every single lesion, whether alone or in combination with other disciplinary teams, to get the full metabolic treatment response. And what really started the acknowledgement in the general community and awareness was this pivotal trial using lutetium PSMA 617. And its results ultimately led, after publication in New England Journal in 21, approval by the FDA for treatment following at least one chemotherapy following castration-resistant metastatic prostate cancer patients. And what it showed was an improvement in the survival and also disease progression-free survival and the overall survival as well. And these are some of the graphs that show quite significant difference compared to standard of care alone. And that included, this is the 15.3 versus 11.3 months overall survival. And then the adverse effects. So we are finding that more and more of our patients, knowing the promise of radiopharmaceutical therapy and knowing also the side effects of chemotherapy, are increasingly asking to see if they can avoid chemotherapy. So currently, we have a couple of trials that we enroll the patients into before the chemotherapy, but we are eagerly awaiting the FDA's announcement on broadening the application of these therapies, even for those patients who have not yet received chemotherapy. In addition to having tolerable side effects, the symptomatic relief, and this, by the way, before these results came out, we had participated in the expanded access program of lutetium 617, and we had already seen that as soon as the treatment has started, the patients feel so much better, in addition to giving them the promise of overall survival improvement. So it's multifactorial benefits of these therapies that are really driving its acceptability across the board. And this is, so improvement of pain, time to first skeletal event, and this is one of the examples of a patient who had PSA level of 425, and in just about 7 months, that PSA has dropped to 17, and you can see confirming on the scan the favorable treatment response as well. This was our very first patient in the expanded access program, and this patient came in the wheelchair, and when we put him in the infusion suite, I was in fact skeptical of whether I'm doing the right thing or not, because he was seen by an oncologist. He was referred from out of town, 87 years old, and it did not look good. He was multiple skeletal pains, as you can see, all the sites in the spine were involved, and unable to even step up. So 4 of us lifted him, put him in the infusion room, and gave the treatment. And when patient came for the next cycle, I was talking with the son and waiting for him to be brought in on the wheelchair. And my nurses come in and say, are you ready now to treat? I said, well, I'm waiting for the patient. He says, he walked right behind you and went into the infusion room. So it's just one cycle. His PSL level dropped to more than 50%, and he walked into the infusion room. And I was convinced after that experience that this treatment is going to continue to provide the benefits beyond just what we see with PSL level drops or survival. It's actually the patient's quality of life is another major factor. And after the VISION trial and prior to that with the NETTER-1 and then NETTER-2 trials, now, as I mentioned, we're getting substantial attention beyond just the field of nuclear medicine of the theranostics. And now we are getting into higher incidence treatments rather than relatively rare, although it's no longer rare. We are increasingly recognizing that neuroendocrine tumors are also being diagnosed at a higher rate. Some of them may be from the diagnostic improvement, but overall it appears that the incidence is also rising of the neuroendocrine tumors as well. So what are the challenges and barriers that we are going through? We will always have the regional differences because of the regulatory framework and the economics of the treatment, the healthcare delivery systems, and the healthcare coverage, whether it's nationalized system or insurance-based systems. But there are still common elements that define the best practice across the board, and they remain true no matter what part of the world we are looking at. So let's look at some of these similarities and differences. Regulatory agencies are going to be different. Radioactive material license almost universally is going to be required, but in a different capacity. We have diagnostic and therapeutic radiopharmaceutical availability is another factor that we will have to make sure we continue to work so that all of these life-saving diagnostic and therapeutic radiopharmaceuticals are available across the globe. Storage, especially with the half-life that we are limited to. Administration techniques, handling of the waste, release of the patients. Perfect example is there are many parts of the world where these treatments are almost exclusively given as an inpatient. And there are other parts of the world, including United States, where they are almost universally given as an outpatient with a few exceptions. Planning and optimization, medical care integration, it is obviously a multidisciplinary effort. Skill set of professionals and training and education. We are finding that the workforce side of it is a significant concern, not only now, but increasingly in the future as the field grows very, very rapidly. So regulatory agencies include the design and subsequent operation of theranostics, guided by the fundamentals of radiation protection. In Europe, it is the International Atomic Energy Agency through the International Basic Safety Standards. In US, it's the Nuclear Regulatory Commission. In India, Atomic Energy Regulatory Board, AERB. And then other parts of the world have very similar entities that are regulating. The basis remains very similar, though. It is a radioactive material license and must cover increasingly all aspects of diagnostic and therapeutic use of radiopharmaceuticals, especially since now we are getting into almost every element in the periodic table is being explored as a potential theranostic promising agent. The RAM license looks into existing of adequate infrastructure, sufficient personnel, the radiation safety officer, sufficient means of protection processes for discharge, management of treated patients, and handling of the waste and sewage part of it. So as I mentioned, almost every element that we are exploring, this continues to grow very, very rapidly. And it's really to the benefit of patients because every disease entity will need a very innovative approach when it comes to choosing the diagnostic and therapeutic radiopharmaceuticals. And so these are some of the common ones on the diagnostic and therapeutic side, and their half-lives become very significant when we are looking at allowing them to be made available in different parts of the world, understanding the infrastructure for production as well as transportation of these radiopharmaceuticals. And then looking at the theranostic pairs, again, increasingly broadening of the available radiopharmaceutical combinations and their half-lives and their energies. For example, you look at zirconium-89, which is newly entering into the diagnostic framework. It has some promising roles in the immunotherapy and immunodiagnostics. It also has a role in dosimetry with multiple time point imaging capabilities that can be possible because of the longer half-life. And then copper-67 scandium theranostic pair is yet another one that is really showing some promise in the future. And then we are looking at specific activity, the radiopharmaceutical that can be made available either through generator or through cyclotron, because obviously this will have the implications on global availability. So there are certain parts of the world where, as I mentioned, we do the volunteering work. One of my work is in East Africa. And they're increasingly starting to depend first on availability of a generator-produced radiopharmaceuticals until the cyclotron capability becomes available. And then I'll refer to this on my future, and what's in the next in the pipeline is also the advantage of the alpha particles and using them in the armamentarium either for patients who have failed beta, or there are now trials that are showing in the beta naive setting where alpha particles are showing some significant promise as well. So as we go more and more into the theranostics, now we are looking at individual lesions for the patients who can be benefited from looking at the energy range. And so you can see that the optimal diameter of treatment delivery on the right column is very different for these radiopharmaceuticals. So we know that Y90, for example, has been used in the targeted liver therapies, and it has a very different applications compared to systemic radiopharmaceuticals, where other options such as lutetium-177 turn out to be better options. And then in the future, just yesterday I was at one of the data safety monitoring board for one of the alpha particle treatment that is in the pipeline for approval by the US FDA, and some of the data that are available are quite impressive on how significant the promise of alpha particles is. And there are several options that are described here on this particular graph. Storage of radiopharmaceuticals is also going to be significant. Provisions of safe storage and custody of radioactive material. Again, various parts of the world have different implications of this. And as I mentioned, transportation to the hospital. So there are few alpha particles that are short half-life, less than 1 day. Their transportation logistics are going to be very different compared to lutetium and actinium that are commonly in the use right now. Dose calibrators, acceptance testing following installation, and then annual testing, well-documented program for quality assurance and quality control, type and frequency to follow national guidelines as they are required by regulatory agencies, shielding administration techniques, so you have gravity-based methods. There are also direct pump methods. There are some automated methods that are coming in the pipeline. And I know there are a couple of companies that are basically developing hands-free robotic systems for the future delivery of these therapies. As the volume increases, we need to be mindful about the radiation exposure of people. And consideration for waste are significant. Some of the lutetium-177 isotopes may have carrier added or non-carrier added. They have different implications of storage and disposal. And then release of patients after treatment. As I mentioned, there are different parts of the world that have different regulatory agency requirements, including dose limit of 1 millisievert per year for general public. I will skip a couple of these slides in the interest of time, and will draw your attention to one of these Lancet Oncology Commission publication that came out in 2021 that really highlights the importance of global access of the radiopharmaceuticals, both on diagnostic and therapy side. And as I mentioned, in the future, the dosimetry is going to play increasing role in the global treatment options for individual patients. And multidisciplinary care, including referring physicians, active role of nuclear medicine with referring physicians is going to be critical. And these are some of the training and experience requirements. We have to be very mindful of workforce pipeline in the future and start working from early high school levels to increase the appeal of radiotheranostics for the trainees and increase the workforce pipeline in the future. We are in the US working on various aspects of it that includes physicians, physicists, technologists, NMAs, nurses, radiochemists, and therapy coordinators. So in just 1 minute, I'll draw your attention to what's coming in the pipeline next. As I mentioned, there are some promises of the alpha particles that are much more broader than the beta particles. There are some of the alpha particles that give you cascade of radiation, although they come with their own challenges as well. But the results that you can see are quite impressive, where there are remarkable sustained treatment effects, saving the patients multiple years of disease-free survival. Another example with bulky disease with just 2 cycles of actinium PSMA, and there's complete metabolic treatment response. So these are the frontiers that we'll have to tackle: personalized dosimetry, radiomics, theranostic pairs, FAPI and other agents, Pentixafor, and new molecules for more common disease entities that are coming in. But ultimately, the goal is to give the patients sustained disease-free survival. So in summary, foundations can be tracked to more than 100 years. There are remarkable achievements and close collaborations amongst physicians, physicists, technology scientists, engineers, and administrations are going to be important in the coming years for growth of theranostics in the future. Thank you.